Our third ask is to fully fund the Agency for Healthcare Research and Quality, AHRQ, next year and going forward. As an agency, AHRQ receives money through the appropriations process. There are three types of appropriations bills: regular appropriations bills, continuing resolutions, and supplemental appropriation bills. Regular appropriations bills cover the funding for the federal government for one fiscal year and are supposed to be enacted into law by October 1. If Congress has not enacted them by this time, as has happened every year since 2011, it may pass a continuing resolution. A CR, as it is called, continues the existing appropriations at the same levels as the previous year. Where we stand now, the current CR extends through December 8th. Come December, we expect Congress to pass another CR that funds the government through September 2018. When you're on the Hill with your elected officials, please ask them to maintain AHRQ's funding in the next CR and not to entertain proposals for the administration or appropriators that eliminate or cut AHRQ going forward. Now let's get into why AHRQ funding is so important. As the largest purchaser of health care, the federal government is responsible for helping doctors find the best possible treatments for their patients. The Agency for Healthcare Research and Quality, AHRQ, is the only federal agency with the sole purpose doing just that. AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work within the U.S. Department of Health and Human Services, or HHS, to make sure that the evidence is understood and used. AHRQ's main goals are to keep patients safe, help doctors and nurses improve quality, and develop data to track changes in the healthcare system. STS collaborates with AHRQ on quality improvement initiatives using the STS National Database. Additionally, STS members are currently receiving AHRQ funding that provides insights in evaluating treatment effectiveness, optimizes patient outcomes, and improves the patient experience. This type of research is not well funded by the private sector or other government entities and will grind to a halt without funding. A summary of research being conducted by STS members with AHRQ funding will be in your materials. The next few slides will take us through some examples of AHRQ funding. AHRQ's research and tools have contributed to significant reductions in hospital-acquired conditions. As you know, hospital-acquired conditions have relatively high mortality risk and include central line-associated bloodstream infections, which has the top-ranked mortality risk among all hospital-acquired conditioners, ventilator-associated pneumonia, and postoperative venous thromboembolism. AHRQ's efforts contributed to a 21% decrease in hospital-acquired conditions, 125,000 lives estimated to be saved, and $28 billion in savings since 2010. A great example of the way doctors use AHRQ research is that of the Comprehensive Unit-Based Safety Program, or CUSP, CUSP. A physician at the Johns Hopkins Hospital developed CUSP and then deployed it using AHRQ funding. He nearly eliminated central line-associated bloodstream infections in the hospital's intensive care units over a 4-year period. AHRQs and other HHS investments have led to a central line-associated bloodstream infections declining by 91% from 2010 to 2015 nationwide. AHRQ develops tools for doctors and nurses to improve safety, quality, and patient engagement. For example, AHRQ funded the development of Project ECHO, a model for improving treatment in rural and underserved communities. Many communities lack the specialists to treat everyone who needs health care. Project ECHO, which stands for Extension for Community Healthcare Outcomes, provides support for primary care clinicians in rural communities. Project ECHO has been adopted by the Veterans Health Administration as a tool for expanding access to high-quality care for veterans across the country. AHRQ also funded a tool for hospitals to reduce avoidable readmission rates, the RED, Re-Engineered Discharge Toolkit. A physician at Boston University Medical Center developed RED using an AHRQ grant. It is a standardized, patient-centered approach that helps hospitals rework their discharge process to reduce readmissions. BU Medical Center found that patients whose care incorporated the RED protocol had almost 1/3 fewer return trips to the hospital within 30 days and an average of $400 lower costs. The Wisconsin Hospital Association used the RED toolkit in an initiative that similarly reduced readmissions by 22% in 18 months, saving approximately $34.1 million. AHRQ's data-centered approach is critical as the nation faces major healthcare issues. For example, an analysis by AHRQ's Healthcare Cost and Utilization Project, HCUP, which includes the largest collection of all payer and counter-level hospital care data in the United States, provided an early flag of rising opioid use and helped target local-level solutions by identifying variations in opioid-related hospitalization rates across the states. State-specific opioid data from HCUP helps show where the burdens on healthcare have grown the most. It may also suggest which states are making the most headway when it comes to tackling the epidemic. AHRQ accomplishes a lot, but some critics claim its work is easily duplicated by the National Institutes of Health. However, this critique, we believe, is clearly misguided. AHRQ focuses on healthcare effectiveness from a population-level perspective, whereas NIH is geared toward efficacy related to specific conditions. For example, AHRQ funds research related to patient safety, care coordination for individuals with multiple chronic conditions, use of electronic medical records, and improving access to addiction treatment in rural communities, all with an eye for cost containment. In contrast, as we know, NIH supports basic clinical research on biomedical and behavioral issues, such as the efficacy of a new treatment approach for specific disease in targeted settings. The perceived duplication between AHRQ and NIH was hotly contested in the summer of 2015 when the House of Representatives Appropriations Committee voted to completely eliminate funding for AHRQ, and the corresponding Senate committee voted to significantly reduce the agency's budget for FY16. STS joined the bipartisan campaign to save AHRQ, and ultimately AHRQ received $334 million in budget authority for FY16, which was down 8.2% from FY15. Clearly, we all recognize that AHRQ supports an important mission of relevance to the STS, our membership, and our patients, and is clearly not duplicated by NIH. In fiscal year 2016, AHRQ received $334 million in budget authority, sustaining a $30 million or 8% differential cut compared with the previous fiscal year. AHRQ funding was cut again this year. The Senate's fiscal year 2018 spending bill for the Department of Labor, Health and Human Services, Education, and related agencies proposed level funding, while the House Labor HHS 2018 bill proposed to reduce AHRQ funding by $24 million. The fiscal year 2018 President's budget proposed that AHRQ be consolidated into the NIH as the National Institute for Research on Safety and Quality, or NIRSQ. Though this drastic step is unlikely, the more members of the House and Senate who understand what AHRQ is and what it accomplishes, the less likely it is to sustain further cuts. Any increase in funding can only become a reality if Congress and the White House work together to pass a standalone labor HHS appropriations bill, rather than a series of continuing resolutions that maintain current funding patterns. This hasn't happened in many years. Thanks to AHRQ's research and tools, the U.S. healthcare system prevented 1.3 million errors, saved 50,000 lives, and avoided $12 billion in wasteful spending from 2010 to 2013. It is penny-wise and pound-foolish, as I think we would all agree, to cut its relatively small budget. Therefore, please urge your members of Congress to preserve AHRQ by maintaining its existing funding in the next CR and dismissing proposals from the administration or appropriators that eliminate or cut AHRQ going forward.